So this is a 32-year-old female with a past medical history of complex Crohn's disease. It is of pediatric onset with perianal fistula and also rectovesical fistula with multiple large and small bowel resection surgeries with residual only 240 cm of small bowel and an ileostomy in 2012. She declined the CTE and last enteroscopy was in 2014 and is only able to scope to 10 cm of ileum from the stoma, and one ulcer was noted. Terminated prematurely due to the intolerance of procedure secondary to pain. The patient has chronic pain requiring high doses of analgesics, tolerance to standard dose of sedatives. And her symptoms is that he has persistent abdominal pain with high stoma output, more than 7 times per day, around 250 mL each episode, but not bloody at all. So she will be having enteroscopy while ileostomy with a per-oral balloon enteroscopy.
I'm now starting the double balloon endoscopy for a patient with Crohn's disease, and I heard that she underwent multiple laparotomies, and she has been admitted to the hospital for about a month for chronic abdominal pain. So we don't know whether she has a small intestinal stricture or what kind of activity she had. I heard that she refused almost all the examinations, and the CT scan was not taken recently. So my plan of the examination is to evaluate her small intestine with double balloon endoscope. So what I will do is examine the jejunum, small intestine, as much as possible endoscopically, and then from the deepest point I could reach, I will use the contrast medium to evaluate the X-ray by X-ray contrast study. Then I will examine from the stoma to see the most active area endoscopically. In that way, I can check her small intestine for the activity and complications like stricture. That's my plan. And talking about the technique of the double balloon endoscopy, small intestine is very mobile and tortuous, so just follow the lumen and push doesn't work very well. For example, here is a sharp angulation. If you make just an angle like this and push, it doesn't work.
Yes.
I usually use the swinging motion. By swinging the tip of the endoscope, I can overcome this kind of, you see?
I can see you are moving the scope, twisting and also moving in and out, right?
Right. So by moving the tip of the endoscope, then the resistance becomes less, and the shaft tries to become straight. So you can make a more gentle curve rather than making a stake. So after insert the endoscope part, inflate the endoscope balloon, then deflate the overtube balloon. Now ready to insert the overtube. And after advancement of the overtube to the tip of the endoscope, then I inflate both balloons. And both balloons are close together now, close to the tip of the endoscope and gripping the intestine. Then I shorten the small intestine with both balloons inflated. By the gripping with 2 balloons, you have a maximum gripping effect. And during the withdrawal phase, I swing the endoscope again to arrange the shape of the small intestine. And then with this arrangement, the next insertion becomes easier.
Dr. Yamamoto,
Yes.
you're using the 3.2 channel scope. That's the new Fuji double balloon scope, is that correct?
Yes, that's right. And you can see a very good endoscopic view like this. This has the focus range. You can come close up to 2 millimeters and still focus. So you can get a bit magnified image of the V-line.
But the length of the scope is the same as the traditional double balloon scope.
Yes,
200 centimeters.
200 centimeters. And the outer diameter is also the same, 9.4 millimeters. So just in and out and twist, and then the tip of the endoscope goes in more smoothly rather than pushing on the endoscope firmly. Because of the multiple operations, she had some adhesion, so it's a bit more difficult than usual case. But still, the fundamental technique is the same. Advance the endoscope and inflate the endoscope balloon and deflate the overtube balloon and insert the overtube along the endoscope.
Now, is it true that in post-op anatomy, sometimes you like to not hold the scope completely straight? Because sometimes you make the angle more sharp if you're holding the scope.
Yes. If the total straightening doesn't work, sometimes because of the adhesion, as Simon said, it could make the curve more acute. In that case, I don't pull too much and keep the curve and go in. Okay.
How are you? How's the progress?
Oh, the progress okay. Because of the adhesion, this is not an easy patient.
Yes,
but,
of course.
You have to be patient, and then you can advance the endoscope gently like this, and I can show you with the fluoroscope the progression. Can you see the fluoroscope image too?
Yes, we can see. I can see you have actually moved deep into the small bowel, maybe still not yet reaching the ileum.
No, not yet. Too early.
Okay. Anyway, I think I still can advance the endoscope. So,
Yes.
And so far, no active lesions.
I see.
So I will try to insert as far as possible, and from there I will get X-ray image with the contrast.
Dr. Yamamoto, can you explain why you're using a soft cap at the tip of the scope?
Okay, I always use a soft cap at the tip of the scope to prevent the red out. Even without insufflation of the air, I can keep a bit of distance from the mucosa to the endoscope. So even with this kind of view, still you can see the endoscopic image, no red dot. Then I can try to find the next luminal direction. So,
but is it also posing a little bit of a problem catching the corners with the cap? Sometimes I find it a little bit more resistant when you're negotiating around the corner.
Oh, and that's the reason why I use the shaking motion often to reduce the friction. I move the endoscope tip. Otherwise, it doesn't slip very well.
Yeah, Dr. Yamamoto.
Yes.
Yes, I can see you may have some finding, right? You have gone deep into the small bowel.
Yes, and now you can see the inflammatory changes, inflammatory polyps and scars, but no active ulceration so far. And I came deep enough
Yes.
And here I use the contrast, and I want to show you the X-ray image. Can I show the X-ray
Yes,
image?
we have the big
Yes.
screen on the X-ray. Yes.
With the double balloon endoscope, as you can see, the endoscope tip balloon blocks the backflow of the contrast. So you can have a good contrast image distal to the endoscope. You see the endoscope balloon is blocking the backflow of the contrast. You understand?
Yes.
Yes. And then no dilatation of the small intestine in this patient, and the contrast is already reached the stoma. So near the stoma there is some tortuous configuration, and maybe stricture over there. So what I would do at home is press that area to separate the small intestine to see the existence of the stricture. So
Yeah, we don't have that here.
yeah, we don't have that press.
Yeah, the paddle, that transparent paddle, yeah, to squeeze on the abdomen.
And then what I would do is examine the small segment of the small intestine from the stomal side. That's my plan. Then
Yes.
We can evaluate the activity of her disease and complication like a stricture.
So when you see these polyp, do you need to take a biopsy, or do you have anything to further enhance the examination of this polyp or inflammation?
Just inflammatory polyp, so I don't think we need to take a biopsy.
I see.
It's not suggestive of any neoplastic changes.
I see.
So I will come back to examine the intestine. So now the endoscope balloon is deflated. So she has a lot of adhesion. So the control is, so you can see the scar.
Yeah.
Yeah, this is a surgical scar, a whitish appearance, right?
No, mucosal scar.
Mucosal scar.
Mucosal scar,
That is because of the Crohn's disease, you see. So the activity of Crohn's disease is nicely controlled on this patient because she's not taking diet. And she has been on intravenous hyperalimentation. So disease activity is under control.
I see. I see. So, okay, thank you very much, Dr. Yamamoto. Thank you.
You're welcome.
Yeah,